Hey guys, so I'm going to talk to you about dentition for a little while. It's not a huge unit, which is why we're not doing it in class, but obviously it's important because teeth are one of the primary articulators. So what I'd like you to do, ideally, is just go through this with me, look at the slides, write down any questions that you might have, things that don't make a lot of sense. I do think this is going to be very straightforward. And then after you finish this, there's an assignment up on Canvas that it's very easy. It's just a tooth mapping exercise that you can submit. And then, like I said last time, when you submit it in the comment section, you'll either put 3 points on the exam or quiz replacement. And I went through the grades and looked it up, and basically it comes out to about the same. So if you have more than 1 0 on a quiz, or really low grade on a quiz, then it's probably better to do that. And if your quiz grades are fine, then you might just want to go ahead and take the 3 points on the test based on how you've done. I'll go ahead and put 2 or 3 more points of extra credit on the test, so it's not your only chance to get extra credit. But like I said, if all of your quiz grades are over, say, 75, you probably want the points on the test. So you figure it out, but just don't change your mind once you put it in, because then I'll never be able to remember anything because I'm old. So, okay. When we're talking about teeth, one of the things that you want to remember is that teeth are bones, and that's why they'll stick around, after we die. I don't know how I've gotten on dead bodies already. But they grow at a different rate, right? So all of your teeth are housed up in the maxilla, so up here in the very top, and down in the mandible. So they articulate with those 2 points. If I ask you about what bone upper teeth articulate with, you're going to say the maxilla, and if I ask what lower teeth articulate with, you're going to say the mandible. And so as a result, we also use these as adjectives. So if we talk about mandibular molars, you know that these are lower molars because they're going to be actually in the mandible or in the jaw. And if we talk about maxillary molars, then they're going to be at the top. So just kind of keep that in mind from an anatomical perspective. So when we're talking about teeth, we talk about the dental arch, and the dental arch is just the shape that goes in the upper and lower teeth. And so out of that arch, you're going to basically have a midline that goes through the middle. So everything will either be distal, and if we say the midline is right between your 2 front teeth. So if something is going to be distal from that, it's going to be farther away from the midline, running through the middle. And the midline goes through the top and the bottom. It basically runs along the line of the intermaxillary suture that's going through your hard palate. So another thing to keep in mind, teeth in the upper arch are lower than teeth in the lower arch, and by lower we mean that they hang down a little bit farther. So more of your roots are exposed in your upper teeth, more of the actual crown and the enamel of the different parts that we're going to go through are actually exposed in the upper dental arch, because some of it's gravity, some of it is development, some of it is use. Because of the way we chew and the fact that we sit up, the gums happen to recede, so it might not even be that the teeth are actually lower, it might be that the gums are higher. But the bottom line is, the reason you have more tooth problems in the upper part and you have more root problems is because the teeth are actually hanging a little bit lower. I don't know if you'll ever need to use that in life, but there's a good piece of information. If anybody ever holds a gun to your head and says which ones are lower, it's the upper part. Okay. So with the dental arch, what I want you to be able to do is be able to label a tooth map. Is it important in adults? Not really. I mean, especially if you're going to be working with the older adults, they're going to have dentures anyway. So the teeth are all going to come in or out. But obviously it's going to be important in kids, right? Because if kids don't have their front teeth, then they're not going to be able to make certain sounds, s and things like that are going to be shh and very strange. So be able to know what the different parts are, because we're going to talk about the stages at which they come in and whether or not things are normal in child development for those of you who are interested in peds. So in the dental arch, we expect in an adult to see equal numbers of upper and lower teeth. In children, it just depends on whether or not they're in a tooth losing stage. That's not the anatomical term, but I'll teach it to you in a minute. So in a normal mouth, you're going to have an upper arch that protrudes a little bit over the lower arch. So we don't want our teeth to have full occlusion. And so one of the things we're going to talk about today, occlusion means contact. And good occlusion would mean full contact in every way. And so we don't want full contact with our teeth, right? We don't want to be like this. We don't want our teeth clenched. It's not good for talking, it's not good for getting the air out, it's not good for chewing, it doesn't leave that little hole between your teeth to get air in and out when we're in quiet or tidal breathing. So a little bit of overbite is ideal. And for those of you who ever had an underbite or who had an occlusion of your teeth, you know that you've had lots of dental work done to try to get that right. And a lot of that is what braces is trying to pull the underbite into just the right angle for efficient chewing. Like I just said, the center of the dental arch is what we call the midline, so that's going to be where the intermaxillary suture runs between your two front teeth, and everything that's close to that midline between the two front teeth is going to be called medial. So we've got medial teeth, or middle teeth, and then distal teeth are going to be farther away from that midline. So all the anatomical things are coming back to you. Oops. Okay. Again, this is a map of the teeth, and you need to know all of these different ones. And so basically teeth are going to be divided into 4 different groups. The incisors, the cuspids or the canines, the bicuspids, which are not on this chart for reasons I'll explain in a minute, and the molars. And so what this chart is showing you is the time at which teeth come in, which we call an eruption. So eruption is when the tooth breaks the surface and then voila, it's there. What you see here is a drawing or a list of how long it takes. So you can see that the first tooth that's going to come in kids is what? Top or bottom? Well, it's going to be the lower central incisor at 6 to 10 months. So, you know, if a child doesn't have any teeth by 11 months, it's probably not the end of the world. But I mean, if we're crossing the year mark, we know something is a little bit strange with development. You know, conversely, kids' teeth can come in at 4 or 5 months if they're very advanced. But the first teeth that are going to come in are your central or medial incisors, the 2 at the bottom, and then the incisors at the top. So the top 2 teeth will be the ones that come in next. So if you look at this chart, I just want you to get a good idea for which teeth are erupting when. Which ones do we expect to see first? If a child is starting to get molars, you know, toward over a year of life, and they don't have their incisors in yet, or they don't have their cuspids in yet, it's kind of like, wait, what? You know, this is something that needs to be discussed with a doctor, not only because it's going to affect their articulation, but why? You know, what's the issue with this development? But definitely for articulation. Children start to talk during the first year of life, which you'll learn a lot more about in Tessa Bent's Child Language Development class, but we want to make sure that the teeth are coming in so that the sounds come in correctly. So shedding is obviously when teeth are lost. And so the first teeth that are going to be lost are going to be the first teeth that were gained. It's going to be your incisors again. So we all remember the first teeth we started to wiggle were going to be the 2 in the middle and the 2 on the top. So what I want you to know for the test is which teeth are going to be the first to erupt, what eruption means, which teeth are going to be the first to shed, and then I want you to be able to critically think of the implications. Okay, well, if a child sheds their maxillary central incisors at 6 to 7 years, what sounds can they not make? Which is a very complex anatomical way to say, what sounds can a kid make without their 2 front teeth, right? So they're not going to make zzz, they're not going to make ch. You know, everything's going to be sh all over the place. So think about that. Like, what if you're giving a child a phonological assessment and they can't make s and they don't have any teeth? Obviously, you're not going to mark them as disordered, right? So that's something that we always want to keep in mind, is that if there's a physiological reason that's part of normal development, then, you know, it's not a disorder. So what we see here is a child's arch, the upper and lower teeth, and so, like I said, one of the things that's missing are the bicuspids, because children only have about 20 teeth. And this is what we call a deciduous arch. So it's like a deciduous tree, where things are going to fall out, right? Because we know all of these teeth are going to shed. And the reason that children have less teeth than adults, I would quiz you on if we were sitting in class, is going to be because they have smaller faces and they can't hold as many, and they don't need all of these teeth, right? So I'm going to go through what each one of the teeth do, but suffice it to say, all they really need are teeth that can cut up Cheerios and teeth that can, you know, help them swallow. They don't need all of these grinding things. Nobody is giving a young child figs to munch on. Nobody's giving them some sort of, oh my gosh, what's something stringy? Forget it. Nobody's giving them something that you have to chew on for really, really, really long periods of time to break down. So because they start with breast milk and then they work on the simple, easy carbohydrates. Nobody's giving them prime rib. That's what I'm looking for. You can tell them a vegetarian. Nobody's giving them prime rib that they have to chew and chew and chew and chew and chew. And so they don't need all of the work from the bicuspids and the molars. So now we're going to go into what each type of tooth does, and that's all I'm going to want you to do for the test, is I might say, name the 4 different classes of teeth and a function of each, and I would want bullet points. This really, I'm sure that you guys have learned this somewhere between 2nd and 8th grade. This is really just a review. Oh, we're not going to go into that. We're going to go into tooth anatomy first. Right on. You see this in the dentist office. I'm pretty sure I stole this from the National Dental Association's website. I just want you to be familiar with the kind of anatomy of a tooth, right? So I'm not going to go crazy about all of this. Just know basically the top of it is enamel. Enamel is the white part. Healthy enamel is the result of calcium, magnesium, all kinds of heavy metals. Underneath we have something called the dentin, and that's basically the little filler that's underneath that will start to show that sort of brownish look if the enamel wears away, which I pray it doesn't. The pulp is underneath that, and its primary purpose is to provide sort of a jello-like cushion for the roots so that they're not banging into things, because obviously the roots are incredibly sensitive. And then down here at the bottom we see, well, we've got our nerves and blood cells, and then right here where it says cementum containing periodontal membrane. Basically the thing here is that the periodontal membrane is what's going to separate your enamel from the dentin. So it's going to be what's inside that keeps the enamel from banging into the rest of it, because enamel is very hard, and so we don't want it to just have friction and be chafing away. So the periodontal membrane is going to be epithelial tissue. If I ask you in a multiple choice question, what part of epithelial tissue is in the tooth, you're going to say it was the periodontal membrane, or vice versa. If I ask what kind of thing that is, I hope to God by now you guys know that any membrane is epithelial, and I know that you do. At the very end here we see the root end opening. Basically this is just where the nerve is going to go down into the mandible, and so each part of the mandible's got a little nerve that's going up into the tooth. If we lose the tooth, then epithelial tissue grows over it so that nerve is not exposed. That's why it doesn't hurt you all the time if you're missing a tooth, because that tissue will grow over it pretty quickly. So, if there are any questions about tooth anatomy, definitely bring them up to me on Tuesday, but I really don't expect you to know more than enamel, dentin, pulp, and that there is a piece of epithelial tissue that's separating the enamel from the dentin. I think you guys are pretty familiar with how roots work in teeth, but if not, definitely let me know. The other part here, I should have told you this first, but we're going to back up a little, is that the tooth is divided into 2 basic parts. So the root is going to be anything from the very, very top of the gum down, and then the crown is going to be everything on top. So all the white part that you see would be considered crown. So when somebody says, I have to go get a crown tomorrow, what they actually mean is that they're going to put a piece of filament over the entire part that's above the gum line. They don't feel that any part of it needs to be exposed to air anymore. So if I do ask you what the 2 components of a tooth are in a fill in the blank, you're going to tell me it's the root and the crown. And then if I ask you about the different parts, you're going to tell me that there's enamel, dentin, and pulp. And if I ask you about the epithelial tissue, you're going to tell me it's the periodontal membrane. And that's it. Don't worry too much about the rest of this. This is just a review of literally everything I just said. I'm very thorough in my mutterings. 3 things that you need to know here that are new. So when we talk about medial teeth, they're going to be the side facing the midline. So whichever side of the tooth if it's your right tooth, it's going to be the left side. If it's your left tooth, it's going to be the right side, but whichever side of your tooth is facing the midline. If it's distal, it's going to be the side facing away from the midline. So pay attention when you're at the dentist and they talk about cavities. If they say there is a distal cavity on the left central incisor, well, they're saying your cavity is on the side that's farthest away from the midline. So it's going to be the outside. And if they say it's a medial cavity on the same tooth, then they mean it's on this side. So anatomy is definitely as much a part of dentistry as any other part. So distal is always going to be the farther away side. Even if it's a close tooth, each tooth has a medial and a distal side. The 3 directions that you don't know yet that are related to teeth are going to be the buccal side. We're going to talk about buccinator muscles in class on Tuesday. And basically, buccinator muscles are the muscles right here that mean bugler's muscles. For all intents and purposes, they're cheeks. So a buccal side of a tooth is going to be the side of your tooth that touches your cheeks. The lingual side of a tooth is going to be the side that touches your tongue. So it's going to be the posterior side where your tongue can rub up against it. And then the occlusal side is going to be the side that touches another tooth. So like we said, occlusions are full closures. And so an occlusal side of a tooth is going to be the point at which it makes contact with another tooth. So if it's a top tooth, then it's going to be the bottom. And if it's a bottom tooth, then it's going to be the top. But obviously these three are in red. I'm not a subtle woman. Make sure you can identify a buccal side, a lingual side, and an occlusal side of a tooth. If I were to tell you where if I were to give you a tooth and say, point to the lingual side, I would want you to know, like in the mouth, which side that is. Okay, now we're going to talk about the four kinds of teeth. I knew it was in here somewhere. So the first type of teeth is going to be incisors. And like we said just a few minutes ago, incisors are the first teeth to erupt. And the lower incisors, central incisors, are going to be the first ones to come in. I don't care on the labeling if you tell me central incisor, if you tell me lateral incisor, I don't care. I really just want to divide it into the four different kinds of teeth. So don't feel like you have to get hyper specific on me. I want you more to know what the teeth do, because I want you to be able to think, okay, if a child is missing these teeth due to developmental problems, due to typically developing problems, what are the things they won't be able to do? And so the first teeth that are going to come in are your incisors, and they basically are spade-like in shape, and they make a thin cutting surface, so they're cutting teeth. And if you ever really watch like a very young child eat Cheerios that doesn't have a lot of teeth yet, you notice they just kind of put the Cheerio between their teeth, and they try to, cut it in half, and then it just sort of spews everywhere, and they're chewing really, really loudly. That's because these teeth are basically just cutters. The macabre reason for that is that they start coming toward the end of breastfeeding, and it's sort of a cue to both of the mother and the child that we might want to be introducing some solid food and wrapping this up. That's not the only reason why, but there's just not a lot of functions that are needed at this point. I mean, if a child's tooth erupts at 6 months, they're mostly still on breast milk and they're still latching. They don't need their steak teeth yet. So keep in mind that these are basically spades. They're like little knives. They make thin cutting, slicing motions in half. And so the central incisors are going to be the two in the middle. And then on the outside of them, you have your lateral incisors, which are smaller with a similar design. But the four of them together are incisors. Mandibular incisors, maxillary incisors. Okay? Moving out from the four incisors, we've got our cuspids. And so cuspids are what are known as canine teeth, unless you're staring at my face right now, in which case you'll notice I don't have any canine teeth. That's what centuries of inbreeding will get you. But for those of you who have sharp little vampire fangs, you will notice that they hang down quite a bit farther than the rest of the incisors. And the point of the cuspids is that they have a single point, or cusp, that's used for tearing. Most of what this is that they show up in all types of carnivores, particularly cats, to separate the fibers of meat. So these are the teeth that are going to get something off the bone, that are going to get, I guess technically the carrot part, but not really. So they're going to pull and separate. So the canine teeth or the cuspids are the ones where you latch in and then you pull. These teeth are in the deciduous arch, so children do develop these along the way. After the point where they're on solid foods, or about the time that they're getting there, they'll start to get their cuspids in place. And so this is when the mouth starts to really fill out, because now we've got 6 teeth. So we've got 2 central incisors, we've got 2 lateral incisors, and we've got 2 cuspids on the top and the bottom. So a nice little set. Outside from the cuspids, we have the bicuspids, and you have 2 of each in the mandibular, 2 on the left side of the mandibular arch, 2 on the right side of the mandibular arch, and then 2 on the top also corresponding. Like I said before, there are 20 teeth in the deciduous arch of the child, 24 teeth in adults, 26 teeth in adults. No. How many times can I screw this up? 28 teeth in adults. So, so you've got, let's just start over and pretend that I can count. You've got your 4 central incisors, you've got a cuspid on either side, so that's 4. Then you've got 2 bicuspids on each side, right? We'll just talk about molars in a minute. It's not important how badly I messed that up. So the point of a bicuspid is that it's similar to a cuspid, but it's going to have 2 points instead of 1. The idea being that, I mean, anything that really needs to be done as far as pulling meat from a bone, a cuspid can do. A bicuspid is more gonna sit, you know, I mean, you've got a point here and a point here, and then you've got this little hole in the middle. So after the food moves from the incisors and the cuspid onto the bicuspid, it's really just gonna kind of sit there in the middle between these points. And then remember, you've got an overbite, so the points aren't perfectly lined up. So imagine that this is your bicuspid tooth. I've got this meat right here in the middle. Well, my next bicuspid tooth is going to fit onto it kind of like this, right? Like on top of that little wad of meat. And so when you start to do this chewing motion, one part is serving as a bowl to hold it, and the other part is just repeatedly stabbing at it. And so it's making it smaller. So the purpose of the bicuspid is really to start grinding that stuff down so that we can push it farther toward the back of the teeth and have it be nice and smooth enough that we can swallow it. Because we don't want big hunks of meat going down into our esophagus. So yeah, with your bicuspids, I mean, you're really starting to do that fine-tuned chewing motion. You know, babies don't eat a lot of pot roast. This isn't a problem for them. But in adults, it's something that we want, particularly because your teeth don't stay equally healthy throughout the lifespan. So while a 20-year-old really could get by with just great cuspids and great incisors and great muscular control over their neck and their esophagus, and everything would be fine, that's not necessarily true as you get older. And so the bicuspids are sort of there as a way to take some of the stress off, get everything really ground down, and then fling it back to the molars so that they can get it ready to make a little wad for swallowing. So you're going to know the difference in a cuspid and a bicuspid because a bicuspid has 2 points. A cuspid just has 1. And you're going to know that the purpose is to crush the food. You're going to be able to see the points of the overbite maxillary bicuspid, and you're going to be able to picture this sort of stabbing motion. And if you can do that, there's not going to be an issue. These are the only category of teeth that are not in the deciduous dental arch. The other ones that I was flubbing math on for are the 3rd molars. But you do have some molars. So if I ask you, what is the only category of teeth that is not present in the deciduous or child arch? You're going to tell me bicuspids. Got it? Okay. Last kind of teeth are molars. Everybody's heard of molars. Molars are basically your large flat teeth that are designed to grind down the material. So we cannot have pieces of whole material going down into our esophagus. It's not good for the throat. It's going to scratch it up. It increases your risk of choking. And so molars are designed to grind that material down. Molars are the last teeth to come in. Let's go back to... Alright, let's go back to our eruption chart. So molars are going to be some of the last teeth to come in. Now, when you can see there's overlap in this chart, right? So some children are going to get a first molar at 15 months and their cuspids in at 18 months. Some little kids' mouths look weird. Ideally, that you're going to grow from the inside to the outside for lots of reasons. Mostly that your jaw is so tiny when you're little. You really don't want to be trying to grow all of these molars while you're still trying to get your face formed and you just got this new jaw that's come together with your symphysis menti. So usually you grow from the midline out, but sometimes you don't. And so the second molars are going to be the last thing that comes in the deciduous arch, but the first molars may come in intermittently with other things. The point being, you're going to grow your teeth as you need them, and so you don't have any reason to be, breaking down these giant pieces of meat into these very, very soft, small things when you're very young, because that's not the kind of food that you're having anyway. You're eating strained pears at that point. And so with your little incisors, you can just sort of grab them off the spoon, and you're pretty happy. So let's see. What else do I want to tell you about molars? Most people have 3 molars in each dental arch. Children have 2. When the molars start to come out, they will be replaced before the 3rd one grows in. The third one is more commonly known as wisdom teeth. And I'm sure most of you have had to have a wisdom tooth out, and if not, that's awesome for you, that like evolutionarily you can handle it, but due to a lot of issues, mating, dating, selection issues, people's faces are just getting smaller and a little bit more feminine, and with that comes the inability to hold all of your wisdom teeth. So it's not going to change that people's wisdom teeth are going to need to come out. It's just that, Neanderthals had bigger heads, and so did early humans. Also, molars get infected a lot. When you have that sort of pain, they get infected. Why? Well, for starters, it's in the back, so they're really, really hard to clean. But also they're really close to your eustachian tubes, and they're really close to your ears. So there's a whole lot of different places that bacteria can come in, and there's a whole lot of inflammation that can happen bilaterally, right? So having an inflamed wisdom tooth can cause an ear infection. Having an ear infection can cause an inflamed wisdom tooth. So, when life expectancy was 30, that wasn't an issue, but now with chronic infections, we do typically get the third one out. But it's your wisdom tooth, and it comes after the first and second one come back in. So even though molars are problematic and they don't fit in our tiny heads, and they're the last things to come in kids, the thing that they are useful for is that they're the most powerful teeth, right? Like, it's very easy to chip a tooth if somebody throws a ball at your head. It's very easy to fall and break a tooth. You don't break a molar. And if you need force, like, I don't know why you'd ever need to bite down on something really, really hard. Maybe if you're like a little sociopath kid and you're like fighting, I don't know. But you don't really bite people with your incisors. Like, it's just not effective. When you need to bite down on something, you bite down with the back because of all the power in your mandible. So you've got all that muscular power on your jaw, and that's what's causing it. So if I ask you about the most powerful teeth, I want you to think about it. You know how powerful your jaw is. You know how exercised it is by talking all the time. And as a result of the molars actually sitting in the hardest part of your mandible, they're your most powerful teeth. Okay. We've discussed all of these things already. I just want you to be able to, like, in very general terms, tell me about the process of shedding the deciduous arch. It's good information to have. It's good for all of your friends when they're, most people spend the first year of life worrying that their child doesn't talk fast enough or isn't growing enough teeth or, like, crawls like an idiot. I don't know. Maybe that doesn't happen for you guys, but they want to know their kid is normal, so here you go. Basically, you want to tell them that, okay, so kids lose their first teeth between 6 and 9 years of age. That is a huge range. That's a difference in first grade versus, like, fourth grade. Then the molars and cuspids can come out all the way through puberty, and then the second molars can come out, all through middle school. That's totally normal. And then when all the teeth grow back in, they're going to be more than they started with, because they're going to get 2 bicuspids and a molar on this side, so it's going to be 3, 6, 9, 12. That's 32 teeth, oh my god. I'm not going to ask you how many teeth, because obviously I don't know. Alright, so the opposite of a permanent deciduous arch is a permanent arch. That's going to occur when adult teeth erupt. Erupt meaning break the surface. So teeth are completely formed in the gums before they erupt. They don't start growing, like, they don't come out as little buds and start growing. Yes, you start to see the crown come out first, but your entire tooth is already formed in. Those of you who had teeth that, it happens with wisdom teeth a lot where we call them impacted, that they don't actually break the surface, but the dentist still cuts out the whole tooth. Obviously, the teeth are going to be fully formed. Nobody is going to want to have teeth come out that are like just root at first, like just nerves. Like, that would be so incredibly painful and awful. So your entire tooth is already down in there beforehand. We call it a successional tooth when a tooth erupts that's replacing one. So a bicuspid can never be a successional tooth because it didn't replace anything. It just grew in because your jaw got bigger, and so then there was an extra space and it came in. Your third molar can never be a successional tooth because it didn't replace anything. It just came in. But all of your other teeth are successional teeth. And so we know that there'll be issues if if the permanent tooth is trying to come in and the baby tooth is still there. And that's not uncommon, that dentists have to take out one tooth because another is trying to grow in its place. So when we talk about successional teeth, just know that means it's got to be replacing something in its space. Okay. This looks blurry in full screen, but it doesn't look blurry in the small screen. So if you're looking at it in full screen, try to minimize it. This is not different than the arch slide, though. It's just a chart. So basically, this is telling you the average age of eruption, just so that you can get a good visual idea of which ones are coming in first. I'm not going to test you on every single one of these. I promise there's no question on the test that says, what is the average age of eruption for the second premolar? Like, and by premolar, they just... they mean the first molar and then the secondary molar. They're using premolar as first molar and molar as secondary molar. I'm not going to ask you about first. I'm not going to ask you about primary and secondary. You got two. They'll come in at overlapping times. It's fine. But I just want you to get an idea of which ones are first. Which ones do we expect to lose first? Which ones do we expect to come in first? Which ones don't come in? And why don't they come in? Okay, like I've been saying, occlusion as a definition is the process of bringing upper and lower teeth into contact. I will ask you on the test what occlusion is, and the reason is because it's not specific to teeth. Occlusion means things are together, so occlusion can be, when parts of a bone are touching each other, they fuse together. It can be, fallopian tubes that are stuck together. It can be, some other things that can be occluded. I mean, you can have a septum where there's occlusion, that the sides have come together. So I do want you to know that because it just means a closure, right? But with teeth, it's normal if it's a neutral occlusion. And so basically, when we talk about our classes of occlusal relationships, there's going to be three, one that's typical and two that are atypical. So the class 1 occlusal relationship, we call it a neutral occlusion, is going to be just that normal light overbite that I was telling you about. It's a normal relationship in a perfect teeth where the upper teeth are so it's measured on the first molar, right? So the first upper or maxillary molar. If the first molar is 1/2 tooth ahead of the mandibular molar, that's a neutral occlusion, and it looks perfectly normal like this. Okay? That's what we expect to see. I know that doesn't look like it's a head, mostly because this looks like a gorilla, and this did come from your textbook, so I bear no responsibility for this. But what they're trying to show you is that the first part of that molar is a head. I'm not going to give you crappy drawings. Just keep in mind, look at the very end part here, and you'll do just fine. This right here. You see how these teeth don't come out very far? Even though it is measured by the first maxillary molar, just look at the teeth. That this is right. This is what you want, because we don't want them to be perfectly lined up or we clench our teeth, and that's weird. And we don't want them to be behind, because then we can't talk or breathe because our upper lip is in the way. So if you look at this part here at the very end, you're going to be fine. But the standard definition is that the first half of the first maxillary molar is 1/2 a tooth ahead of the mandibular molar, and they have illustrated that for you by making it look utterly confusing. Sorry. Okay. The second type of occlusion is a malocclusion. So the difference in an occlusion and a malocclusion is that an occlusion is a closure, and a malocclusion is a bad closure. So a class 2 malocclusion is going to be what we call an overbite. And yes, a neutral occlusion is an overbite too, in the sense that they're not even, but this is what we mean when we say, oh my god, she's got an overbite. Like, it's really noticeable, it's really far. And so basically what happens here is that one of the molars is at least, okay, that is not what I meant to say. With the, just listen to me here. So with the class 2 malocclusion, the maxillary molar is going to be at least 1 tooth ahead of the, oh, no it is, I just put it in the passive because like everybody wants to do that. The first mandibular molar is retracted at least 1 tooth behind the first maxillary molar. If I had said that in a normal way where you'd remember it, I would have said the maxillary molar is 1 tooth ahead of the mandibular. So in a normal overbite, it's going to be ahead by 1/2. The first molar is going to be ahead by, like, in front by 1/2. With an overbite, it's going to be at least 1 tooth, and maybe more, depending on how severe the overbite is. And so then you come into issues where there's not good occlusion, where you can't make, you can't make a really tight jaw, you can't make a really tight closure. And we don't want that, right? Because we do need closures for things. We need it for sucking on a straw. We need it for all kinds of, we need it for being able to hold our breath. And so we don't want that to come out too far. And that's a lot of times when you guys get braces, it's because you had a class 2 overbite, and they typically come from sucking thumbs or being on pacifiers too long, that kind of, normal kid stuff. Okay. A class 3 malocclusion, so the class 1 was just an occlusion, it wasn't a malocclusion. Class 2 was a malocclusion and it was an overbite. Class 3 is a malocclusion and it's an underbite. So the first mandibular molar is advanced farther, at least one tooth ahead of the first maxillary molar. So the first tooth, the maxillary molar, was farther, right? But here the mandibular molar is going to be farther because your lower jaw is going to stick out farther than your upper jaw. As you can see here, this is what's going to come out. And in 99% of cases, an underbite has to be corrected with braces or surgery because without having taught you the muscles of the skull yet, basically what happens is if you try to stick your jaw out right now, and I encourage you to do it, you're going to feel a lot of tension right here. And that's your temporalis muscle, which is going to be on the temporal bone that we talked about. And if you have that kind of stress and tension on this muscle all the time, all your life, you're going to have migraines and headaches and vision problems from the muscular effort, and it's not good. So everything but the most slight of underbites is usually corrected. Okay. I basically gave you this slide just to show you more of the difference between occlusion and malocclusion. I am not going to test you on these per se. I want you to just think about them in terms of, how we've been breaking down words into their, little parts. So if a tooth is labioverted, it means that it's tilting toward the lips. So instead of going straight up, it's kind of coming like its top is forward, so superior surface is pointed anteriorly, right? A tooth that's tilting toward the lips. If it's torsiverted, it's twisted to the inside or out. If it's linguaverted, the tooth is pointing toward the tongue. And if it's buccaverted, then the tongue is twisting out into the cheek. Like I said, this is not the biggest focus here. This is an articulatory unit, but just kind of getting used to these terms in case you see them, because if what you're really dealing with in peds is, children that don't have any cognitive problems, that don't have SLI, that don't have like a real brain issue with speech, then you're probably dealing with somebody who's got weird mouth stuff going on, in which case you may very well see these terms. I'm more interested in the ones that have like huge brain problems, but if this is what you want us to be, a school therapist, then yeah, you're gonna see a whole lot of his teeth are messed up and here's how. I wish I didn't have to say his, but most of your patients will be boys, so don't wear anything nice. As far as positional terms for malgrown teeth, here are a few others. Distiverted is going to be pointed distally, so it's going to be away. Mesioverted is going to be tilted toward the midline, so your teeth are going to kind of lean toward the center. Infraverted is going to be one that doesn't come up enough, so it's pointed back down. It's like it started to come up and it went, nope, I'm not doing that. And then supraverted is going to be one that comes up too far, and as a result, it's going to cut off the proper point of occlusion, which I'm going to show you some examples of supraverted teeth positions in just a second. Keep that one in mind. Supraverted is one where the teeth came out too far, and so now we don't get that good occlusion that we're looking for, the healthy occlusion. Okay, so speaking of supraverted positions, if the teeth in the posterior arch, by posterior we mean these back teeth, these molars, these bicuspids, if they grow too high, they prevent the occlusion of the incisors, and this is known as a persistent open bite. So if these teeth grow too tall, for whatever reason, then the teeth in the front can never really close, and we'll call that a persistent open bite. The opposite would be known as a persistent closed bite, and here are some pictures. So here you can see the persistent open bite, there's always a gap between the teeth. They never really close. Typically these people have much longer canine teeth. It's kind of strange that you would have the teeth that grow later, grow so much longer, but, people's mouths do strange things. And then the opposite we see here on the right is the persistent closed bite, which is basically the incisors grew longer, and because these teeth grew so much longer, the ones in the back don't ever fully close. So I mean, what kind of things do you think you're going to hear if somebody's got either one of these, right? We hear a lot of whistling in their speech, a lot of frication, because they're never going to get a good t or p or k. If they can't really get their teeth together, there's going to be a whole lot of air coming through. They might, have sort of a lispy sound or a whistly sound to their speech because of having that turbulent airflow all the time. Typically in situations like this, I mean, if there's not a real medical problem, they'll just shave, like in the persistent open bite, they'll just shave down the canines, and that's not a huge deal. And with the persistent closed bite, they'll usually put caps on all of the back teeth to make them longer so that they'll close. So, in addition to the fact that your speech is going to sound weird, what else is going to be kind of weird if you have a persistent open or closed bite? You're not going to be able to chew your food normally. Okay. That's all I want to tell you about teeth. That's more than enough information to do the little assignment. I will test you on teeth. I will answer your questions on them, but I didn't think that was worth taking up a class period when we could review all of the awesome face bones and muscles that you guys forgot over break. So while I have your attention, I thought we would do a quick review of source filter theory, just because we did that at the end of the last class before spring break, so I'm sure you guys remember it really good. Basically, with source filter theory, we're saying that voicing is generated in the vocal folds, which is phonation, which we all know very, very well at this point. And then voicing is routed through the vocal tract, which is a series of tubes. And those tubes were the oropharynx, the nasopharynx, and the pharynx. So basically, that phonation is coming up through a series of tubes, right? And we said that any tube is going to resonate at the most efficient frequency for it. And so if the tube is bigger and longer, then the frequency is going to be lower, which is why men have deeper voices than women, because if you've got a bigger chamber, then the sound wave is going to take longer to get through the entire tube. And so it's going to have a lower periodicity and it's going to be slower. If the tube is really, really small and you're pushing the same air through it, then the frequency is going to be higher because the wave is going to die out faster and the next one will come and the next one and then the next one, right? So what I want you to know is that the most efficient resonant frequency in a tube is the one that will be chosen unless we alter the shape of the tube. And so, positioning our articulators is how we alter the shape of our own tubes so that we can get varying frequencies. And varying frequencies correspond to vowels. Like if you do any sort of acoustic measurement, you know that this is how we differentiate each vowel. Like, yes, perceptually we know the difference in ah and e because we can hear it, but the way we measure it is that they have different formant frequencies. And so the parts of the body that are going to alter the shape of that tube are going to be the mandible, the tongue, the soft palate, or the velum, which we're going to talk about Thursday, and the teeth. Those are going to be the things that make the tube either bigger or smaller. So the mandible is either going to make it high frequency because it's going to be close together, e, or it's going to make it like lower frequency because it's farther apart, ah, e, ah. So that's what's changing it. The tongue can be contorted in a lot of different ways to make a septum. So there's air going above and below, but it's not the same as a big open ah cavity. The soft palate can be raised, and when the soft palate is raised for nasal sounds, it's going to make the cavity bigger, and then the teeth, of course, can make things can go closer, like s, e, or they can be farther apart, ah, and it's the same concept that it's going to change that frequency. Resonant frequency, you do need to know. That's what I'm talking about when I talk about the periodicity of the wave. Resonant frequency isn't different than frequency. It's just that we're talking about the container more than the sound wave at this point. So we're talking about frequency. We're just talking about what the sound wave is, and now we're talking about what the sound wave is inside of a tube. So what actually having the shape around it does to mold it. So if you understood frequency before, now just think about it in terms of, but if we contain the frequency and then we change the container size, then we can change the frequency itself. And the two main factors that are going to change that frequency are going to be length and volume. So this very much corresponds to what we were talking about with falsetto, about thin reed-like vocal cords, right? If you make your speech really, like if you make your vocal cords and the tube very long, then you're going to get a higher frequency. And if you grow and get bigger, then it's going to lower the frequency because you have more space. Okay, so I straight up will ask you on the test, what are the two components that make up resonant frequency? What are the two things that can be changed? What are the two main factors? And you're going to tell me volume and length. And then if I ask you how resonant frequency works to change the vowels that are being produced, you're going to tell me that moving the articulators, you can choose the tongue, you can choose whatever, moving the articulators changes the cavity shape. By cavity here I mean mouth. Changes the shape of the mouth, and that will change the optimal resonance frequency, because if the tube gets smaller than the optimal or most efficient frequency will get smaller, will get higher, and then if the tube gets bigger, then the optimal resonance frequency will get lower. So the biggest and shortest resonant frequency vowel is going to be ah, and you know this. I mean, you know how your chin goes down. And then the longest but thinnest is going to be E, and that's going to be your highest frequency. So if I do ask you about one of those segments, those are going to be the two that you choose from in English. Other languages have different parameters for this and have the U and stuff like that. I gave you this definition of speech last time. Basically, speech is the product of sending sound produced by the vocal cords through the filter of the vocal tract for the purpose of making meaning. So, I guess now is not the time or place to go into a debate about whether babbling is speech, but typically it's for meaning. Okay? So these are the page numbers in the book. If you want to review any of this, I don't think you need to. I pulled out for you what I feel is relevant for what we're trying to accomplish in this class, but if you want to read it in somebody else's words, I encourage you to do so. Don't forget the three components of the vocal tract. If I ask you, oral cavity, I called it the oropharynx earlier, whichever. The pharynx and the nasal cavity, or nasopharynx. Just know that oropharynx is the oral hole and nasopharynx is the nasal hole. Okay? So for your extra credit activity, you're going to go to the assignments, the dentition assignment, and then you're just going to fill out the tooth mapping thing. It's a Microsoft document, so just, download it, edit it, send it back to me. Mark whether or not you want a quiz or you want 3 points on your next test, and you're not going to have any problems with it. Nobody's going to have to ask me any questions. If you do have questions about anything I said during this unit, though, please write them down and let's discuss Tuesday or Thursday, because these things will be on your test. Not as much as the things I'm going to go over this week. We're going to go over chewing and swallowing, but it will be there, and you will be expected to know it. But I think you guys are doing great. Anybody that watched this is definitely on the right track. So if you have questions, please let me know. Take care, guys.